Good evening, everybody. It's 8 o'clock, and welcome to today's episode of Marvelous Medicine. The topic is what makes a good surgical teacher. We are extremely privileged to have Dr.Ramesh Ardhanari, Dr.H.Ramesh, and Dr. Sadiq Sikora to have a chat about this topic. And special pranams to all our gurus, Dr. Ananthakrishnan, Dr. Robinson Smile, Dr. Samiran Nandi, and perhaps many others who I have not noticed. All three are stalwarts, but still, for the sake of Marvelous Medicine audience, can you just give a brief introduction about our three speakers today?
It's my absolute privilege to introduce these three stalwarts. And these stalwarts got into GI surgery during the open surgical era. Then they walked into laparoscopic surgery, then into robotic surgery, then into transplantation. All three of them. And actually, they have a very unique place in the history of surgery that they have been in this transition zone. And of course, Dr. Sadiq, he had his earlier surgical training in the All Indian Medical Sciences, and subsequently he held a very senior position in Sanjay Gandhi Lucknow Department of JCG for a long time before he moved on to the corporate sector. And presently he is heading the Department of Surgical Gastroenterology and Liver Transplantation at Sakra Hospital, Bangalore. Dr. Ramesh Ardhanari is known to every surgical trainee in the country, and he had his initial education in CMC Vellore, then the All Indian Medical Sciences, and subsequently Madras Medical College, and he presently heads the Department of Surgical Gastroenterology, Robotic Surgery and Transplantation in Meenakshi Mission Hospital, Madurai. And Dr.H.Ramesh is another big stalwart. Actually, Ramesh and Ramesh is, together known so very well across the country. Dr.H.Ramesh is known for his foray into pancreatic surgery, and he has his training in PGI Chandigarh. And presently he heads the Department of GI Surgery and Liver Transplantation at Lakeshore Hospital, Kochi. Vidya.
Yeah, Dr. Ramesh Ardhanari, if you could just tip your camera a little bit, your face is getting cut off. Yeah, thank you so much.
Yeah.
Dr. Sadiq has got a lot of exciting questions planned for both Dr. Ramesh Ardhanari and Dr. H. Ramesh. Dr. Sadiq, perhaps you could wait for Dr. Ramesh to get home before having any direct questions at him. Let him join in when it's convenient for him, since I believe he's driving. Thank you so much, Dr. Sadiq, for your enthusiasm and planning this session. Over to you, sir.
Good evening, everyone. And it's a joy to be on Marvelous Medicine. I used to hear about this from Puneet and finally have made it, so as to say. And it's obvious that it's a session which is of very high standard, because I wouldn't think that Dr. Nandi, Dr. Ananthakrishnan, and so on and so forth would spend their 1 hour on a webinar unless it is an exciting place. Also, a topic which we are going to discuss, they are integral to that, and they would be seeing some glimpses of themselves in that, or they would consider that we've not attended enough of their sessions to understand how they've taught us surgery during this period. Ramesh, what is your ETA?
In a few minutes, in 5 minutes perhaps.
Okay, so
but I can take questions. I'm on hands-free, so it's not a big deal.
So I mean, it's a very interesting topic what we are discussing. It says what makes a good surgical teacher, and what I want to tell my both panelists is that it's about us today, not about whom we are sending the message to. And let's try to introspect and see how we have gone through it and what we are able to give to our students. But let me start with Ramesh, that, you've been...
Which Ramesh? Which Ramesh?
Ardhanari. So you've been done your MS, MCH, and have been a teacher after that. You've gone through many generations of teachers and students subsequently. Tell me what the teachers which have influenced your life and what
Yeah,
impact they had in your career.
yeah. So, if you, when I look back, uh, the first surgical influence on, I see, I always wanted to be a surgeon. Even in school, I wanted to be a surgeon because when I was in school, that was the height of cardiac thoracic surgery with the heart transplant, reading about Barnard and Cooley and DeBakey, and so I wanted to be a surgeon so all my life. So when I came to Vellore, Dr. A.S. Fenn was obviously the person who was sort of a hero to many of us. Many Vellorians became surgeons because of the influence of Dr. Fenn. Then I came to All India Institute and I worked with two surgeons, and they were both chalk and cheese. But I learned so much from both of them, Professor L.K. Sharma and Professor T.K. Chatterjee. I learned how to make decisions, how to operate, how to lead a unit, and how to talk to patients. I owe them almost everything that I learned. At the same time, though I never worked directly with Professor Nandi, Professor Nandi was a hero to all of us, I think, in the Department of Surgery, even those who didn't work with him, because he was a wonderful speaker. He had done a lot of work. He was very much appreciated, and his personality and the way he would talk in meetings, I think all of us wanted to be the Nandi of the next generation. So he was one of the influences, though he never directly taught me, but I have always held him up as one of my heroes. From Dr. Rangabashyam, I learned a lot, especially how to project your work, which I had not learned so much in institute or in Vellore. But he was always, take photographs, keep taking, and then present the cases. And so, we learned, all of us, those who were trained in Dr. Rangabashyam, H. Ramesh, Surendran, me, G.V. Rao, we all learned how to, present our work. Chandra Mohan, foremost among us in doing that. And so we kept documents and photographs, and we learned how to do that. So these are the people who sort of inspired me. But I must not forget two or three others who are not my teachers directly, but who have been great inspirations in my life for surgery. One is my friend Surendran, who was professor of surgical GE, built the largest standalone government GI surgery center in India at Stanley Medical College, and Dr. C. Parnivello, who I have always regarded as a sort of a mentor in laparoscopic surgery, and because of whom I took the interest in laparoscopic surgery and I came to where I was in laparoscopic surgery. So these two gentlemen and a third gentleman who trained me in institute, from whom I learned how to be meticulous in your work, meticulous in your speech, how to work hard, how to maintain records, Vinay Kapoor. So these three I owe a great debt of gratitude. Also, though they were not my teachers directly, but they were my uh, contemporaries, but from whom I've learned a lot.
So we have a lot of common thread, Ramesh, because I think as far as I'm concerned, the heroes in AIMS were, the surgeons who would be, you would want to emulate, were Dr. Nandi and Dr. BML Kapoor. Sometimes we used to feel that we've landed up in Unit 1, but we saw the best, as you said, the chalk and cheese. And Dr. Chattopadhyay gave us the freedom to operate with the anatomy he was so good at. We learned that from him, and the surgical techniques. And Dr. Sharma was a patient teacher. I mean, I have not seen a professor of surgery scrubbing with a first-year resident and getting through the lab, open cholecystectomy at that time. So we learned both the things, many things from these teachers, and they were always looking after our interests. And I thought that was the thing which impressed me about the teaching and the surgical teachers that they were at that time. Ramesh, are you in a position to tell about your experience? I think we'll get back to it. But Ramesh, you told me this, but what do you think should be, or what do you look at? Oh, Ramesh is here.
Yeah, can I
Ramesh,
speak? Is it all right?
you want to tell us who
Yes.
has
Yeah.
influenced and
No, I was,
what
I was,
impressed you about that?
I was pretty much a medical student in clinical medicine, and I thought I was going to be a physician until I joined my internship, and in Professor Mohan Rao's unit in Roypeta Hospital, and there was an assistant surgeon called N. Mohan, who is still my surgical spiritual guru in every way, because in the 1st of February 1981 it was, he had managed to convert me to become a surgeon by just showing me around, by showing me all that was interesting in surgery, by teaching me so much in one day, by giving me so many life principles. And to this day, I owe most of what I've achieved, if I've achieved, to his initial words: take care, do the job properly, don't worry about the time, close the abdomen or the skin properly, hemostasis, no tension. All these principles were taught by him, and I was completely, spellbound, and I never recovered, I guess. I went on to PGI, and I came to meet a man who led rather by example in terms of acquisition of skills by application.
We're losing you in between, Ramesh.
Dr. Ramesh, if you don't mind, we'll get you back again once you've reached home, because your voice is breaking.
In terms of strategy building, and also in terms of commitment to patient care. I'm hoping.
So, Ramesh Ardhanari,
Yeah.
so we are talking of a good surgical teacher. Do you think they are born, or they acquire it during the period of their career? And what are the
No,
attributes of a good surgical teacher?
see, you can become a good surgical teacher with training and this thing, but to be an exemplary surgical teacher, a mentor, someone to whom people look up and say, "Oh, look, I want to be like him," then I think to an extent that is an inborn characteristic. These surgeons generally have similar, should I say, characteristics. They are, of course, good surgeons on the table. They are good expressionists. They can put their point across forcibly and well. And they are good speakers. And they are the people who take time to teach. On a step, in the theater, there are surgeons who will just quietly come, do the surgery, and just walk off without opening their mouth. But then there are others.
Exchange and be
Yeah.
interactive.
And tell the postgraduates assisting them why you're doing that particular step, and why you are going to do it in this way, or when you take a decision. For example,
We'll come to decision making and all.
yeah, but all that is part of the surgical teaching that you do on the table. So what I mean to say is that a good surgical teacher can be made, but a brilliant teacher, I think, is partly born. I mean, all the coaching in the world cannot make a Sachin Tendulkar or a Brian Lara. Let us be clear. The coachings can make the average player into an okay player, but they cannot bring the genius of a Tendulkar or a Lara to the field.
So you need to have some inherent characteristics, the ability to communicate, to have a rapport, to be able to share your experiences openly, and at each step, be available for the student.
And a truly good teacher would also tell his students of his own failures and tell them that I did this wrong and I have learned it. And I am telling you this so that you don't make the same mistakes. You can avoid it. So that would be a truly not just show off your successes, but also tell them about your failures so that they learn that failure is part of every surgeon, no matter how good he may be.
Right. Ramesh, we just briefly saw you.
Yeah.
Can you switch on the video?
Yeah.
We'd like to see you when you speak. Yeah.
Actually,
So sorry we lost you in between, but I was asking that what a surgeon teachers born, or they can be trained and become a good surgical teacher.
I'm sorry for sounding a little different because I don't. Teaching is just
The
another.
volume.
Okay. Is that better now?
A lot of background disturbance.
Sorry for this. Can you hear me now?
No,
We
it's
still have the background
very
disturbance.
soft.
I think you may have to mute your the speakers on your desktop so that the feedback doesn't come.
So Ramesh, you mentioned about the decision making, teaching, and all. So there are several components of surgical teaching. You know, there's a theoretical component, there is a technical component, there is a decision making component. Now, just give me an idea that which ones are important. I'm sure all are important in their own way, but as a teacher, how would you want to sort of impart these components to a student?
Well, if am I audible now?
Very soft, Ramesh. Very soft.
I'll probably log in again. So
Yeah,
just
please do. Please do. Yeah,
So,
Ardhanari, you can take that.
yeah, so as far as I am concerned, they are all equally important concerns. The problem that we face in India, I believe, is that 3 years of training in the basic of surgery, MS, is just too short. I think that people, when they finish their MS, they think they can do everything. 3 years of MS is not sufficient. I think a 5 year course is what is required, or if you're specializing, 3 years after MS, 3 years of specialization, then you become an expert in your field and you specialize. But if you want to stay a general surgeon, I think even there you have to train for some more time in as a senior registrar in a major institution. And I think that is something that we lack. The duration, I think, is off. And I think that we have, I don't think
So there's
the
a
NMC is at all gone on.
3-year MS and a requirement for 3 years of senior residency before you get a position. Isn't that, you don't think that's even enough in general surgery?
That is enough. They must do the 3 years of senior residency before they become into a teaching line or before they are appointed as a specialist at a hospital. But I see people are appointed as specialists at a hospital with just an MS and sometimes even with just an MRCS. They have written the exam from here and passed the MRCS without any training, and they become consultants. I think that is wrong. They are not trained sufficiently.
So what is the way you sort of communicate to your students in terms of the finesse and intricacies involving decision making in a particular situation? How do
So,
you
oh,
interact with
so,
them?
so, so in our unit, we have all these every day morning before we go to the theater or start the rounds. We look at all the admissions of the previous day. look at all the cases we did the previous day and discuss whether there were some problems. And so each of the cases we go through rapidly in a room with all the postgraduates and all the consultants sitting. And we make some of our decisions, or we say, no, we'll have to take a look at this patient. So there, the doctors learn that sometimes the consultants want to see the patient, want to see the condition, want to see the abdomen, and then take a decision. At other times, based on the investigations and the history, they say this is clear cut and this is what we will do. So they understand then that where you need to introspect by looking at the patient in a greater depth and then take a decision, and where you can take a decision straight away based. For example, you have a biliary colic, you have right hypochondrial pain, 35, 40 years old, gallstones on ultrasound, LFT is normal. That's a patient for a laparoscopic cholecystectomy straight away. So
So you
we
mean
need
to
not
say
see
the
the,
common sessions, getting them together, and then
yes.
do you ask them to take decisions and see?
We ask them what they will do. Yes, we do ask them, what will you do now? And sometimes they'll come out with the right answer. Sometimes they will just keep quiet. Now, most of the time, I found is that our postgraduates keep quiet in front of the seniors. They don't like to express themselves because they don't want to be told that, no, that is a wrong decision. But I think you and I, we were there, we would express our opinion, and if they told us we were wrong, we'll accept it and move on, but
What,
we would open our mouth.
what do you
Yeah,
think,
I
Ramesh
feel
Hariharan, about the modus operandi of communicating and teaching decision making?
Each one of these aspects is important, as you were asking me, which is important. So, as you rightly said, each one is important. And what is more, I think you teachers set an example. If they show a visible approach to strategizing, to planning, to patient communication, to actually delivering on the on the ground, and also showing commitment to follow up, documentation. Each one of these components, it's very easy to give lectures and tell people what to do, but the best way to do it, in my opinion, would be to set an example. And if you showed each one of these qualities in your professional life, your mentees or trainees or colleagues would imbibe it to the extent that they wish to have it. I would therefore not, be a great fan of, didactic, delivery of certain fatwas to say, do this, do that. I haven't found that very productive. In my own case, I would much rather imbibe rather than be told what to do. And therefore, what is good enough for me is good enough for everyone else, according to me. And therefore, I've always believed that you can only set an example. And
So,
each one of these facets you have to highlight in the course of that example. Of course, there is a process of assessment of your mentee. So constantly you have to look upon our mentees have become our children, basically. So you have to stay away from them, let them grow at their own pace. Some of them are faster learners than some others. So like you do with your own children, they teach you a lot of how to hands-on and hands-off both at the same time. So here it is much easier because they are not really staying at home, but they are in a way staying in your home, in your professional home. So you have to watch them out of the corner of your eye. Sometimes you point out glaring issues, but that also you have to time it properly so that it goes down the right way. After all, the task is to get the job done in a productive way, not to simply point out mistakes and simply completely demotivate the
yeah,
train.
yeah. I think uh, this is the sort of style which we all uh, uh, carry out, and we all agree that this is perhaps the best way. Let me just get two senior teachers here for their comment on Dr. Nandi and Dr. Anantkrishnan. Uh, what do you think is the best way of imparting the students the way of going about making a decision during surgery? So there are a lot of times we need to make intraoperative decisions. How do you think when you do that, do you just continue with it? How do you make sure that they are able to understand why you have taken a decision?
I think I've been very disappointed in the progress of Indian surgery over the last 40 years. There is too much hero worship, and there's too much stress on the technical aspects of surgery. And what we must teach the students is how to think and how to become surgeons who are better than us. And I always think that there are four aspects to a surgeon. One is patient care, which I think is important, but not everything. The second is teaching. What you teach is not impart knowledge, but stimulate people to think. And I'm very interested that people, everyone, should do research, especially in academic institutions. And research, and we've done a lot of studies on this, from Indian surgeons is very poor. And finally, there must be some contribution to society other than surgery. And I think that the only thing that I'm proud of in India is the liver transplantation, which is now India does the largest number of living-related liver transplants in the world. And the reason for this is money and also lack of control. But still, it has produced a lot. I think that we have a huge opportunity to lead not only the third world, but the world. But we must instill into our students not to hero worship so much, not to think of seniors as gods, but to become better than the seniors. And I feel wonderful if someone that I've taught has done better than I have. That's the greatest achievement to my life.
Thank you. Thank you very much, sir, for your always wisdom which comes to us and uh, makes us keep on thinking about what is the best way to go forward. Dr. Anand Krishnan, would you like to?
I'm here. Can you hear me?
Yes, we can.
Yes. Thank you, Sadiq, and thanks to Patta and my two Ramesh friends. Glad to see you all. Although we met recently in the Epitobiliary conference, Ramesh at least, Ariran Ramesh and I met. And the thing is, if you want to teach surgery, there's no such thing as a reluctant teacher. And that is very important. You want to share what you know with those who are going to follow in your footsteps and become better than you. Most of my students, over 30 years in JIPMER, 25 of them are liver transplant surgeons all over the world and very, very skilled at what they are doing. We take pride in their achievements. The thing is that teaching comes by walking the talk, not by giving advice which you don't follow yourself and which they can point out to others. This fellow is full of advice, but look how he behaves. So if you do that consistently and softly without being destructive, because everybody makes mistakes. I worked with a lot of different types of surgeons in Dr.Patta Hospital, in KMC, where I did my MBBS. Of course, they were also extraordinarily good teachers like Sarat Chandra, and also 7 years at All India Institute with Dr. BML Kapoor, and later on with Dr. Manmohan Kapoor. That's the latter part is when Dr. Nandi joined, and he became a hero to all of us. Whomever I worked with, I found that they are disciplined, firm in their beliefs, but never destructive, and always walk the talk, behave in a way that they expect you to behave. That's the first quality that I appreciate. The second is, as I said, once you join the profession of teaching, there's nothing like a reluctant teacher that you come, you operate, and go away. You expect that what you're doing so facilely is not going to be easy to others because you've gone over the learning curve and you're now on the other side, but they are learning, and therefore you have to take time off, not hurry through, and explain the critical steps to them, the possible mistakes which you have made yourself or likely to have made or seen others make, so that they can avoid it, spend a few moments and clarify their doubts, why you're saying what you're saying. And the third thing is, if you expect them to do hard work, you cannot relax. You must show by your example that you are prepared to work as many hours as you expect them to work, and not only allot the work to them and sit back and only criticize. I had the pleasure of working with Tushar. He was my first postgraduate student when I was a senior resident in Dr. Manmohan Kapoor's unit. And there are many like him. There are some who take a little more cajoling, a little more persuasion, but harshness never works. And of all 500, 600 surgeons who have worked with me over the years, both at GIPMER, at All India Institute, and later on after GIPMER in wherever I'm working now, I think they respond to advice in a very positive manner. They respond to example in a very positive manner. And if they know that you mean what you say and you want to share your knowledge with them, they are willing to oblige. After all, knowledge is the only thing. The more you share, the more it increases. And therefore, you don't have to worry about sharing your knowledge. I never had difficulty in getting on with any resident in my life. And I think they know that I mean what I say, and they know that I will do what I say. That's all, Sadiq. I have nothing much.
Thank you very much. So I love you can't be a reluctant teacher. And what Dr. Nandi said, that we need to make them think rather than dish out in a platter what we would like to communicate to them, but stimulate them to think. So thank you very much, Dr. Nandi and Dr. Anand Krishnan. It's always a pleasure. So Ramesh, we get back to this Hariharan. Again, as we said, there are multiple components. There's theory we get from books, journals, and evidence-based data, trials, randomized trials, level 1 evidence. Then there is decision-making, intraoperative decision-making, and post-operative management of these patients, which you will not get in textbooks in a defined manner in a particular situation. So these are important, we all realize, but how do you think we should be giving this and making sure that they understand and absorb this kind of these important components of surgical training?
Well, I think the teacher has to make it clear that he or she can be fallible, that they are also processing information. The information, their case is derived not only from the studies that you mentioned, but in their own analysis of those studies and in the clinical experience that they have acquired, obviously each one of us is accumulated varying degrees of wisdom, and from time to time this wisdom fails us too. So we have to come across as fallible, but people who really care about getting the right decision executed in the right possible manner. So in a way, it's an expansion of what Dr. Eki said about walking the talk. That if you demonstrate that interest, then it is very clear that many decisions of yours may be right, but some others may not be. And even in those which are not right, to have a formal audit, to have a formal meeting, to actually highlight these. And it's important to hang the crime, not the criminal. It's really critical to identify what could have been done differently. That approach really is an eye opener to the teacher themselves, as it is to the so-called mentee. And in any case, I hate the word student because we are all students forever. And I always have arguments with Vinay Kapoor because he says students must come on time and things like that. I said, what about our students? We students must come on time. So we all have to, go through that process.
So these are general, points which you are mentioning. Are there anything specific we can do that these components could be given to them? So in your practice, in your uh, unit, in your department, how do you ensure that these aspects are communicated?
May I give an example and give you
Yes.
yeah.
Yeah.
So about a few months ago, we had a patient where we operated, and on the very first day, there was in the drain a fair largely amount of bile. However, he was a elderly gentleman, so I didn't immediately explore. We managed him conservatively, but then he had multiple other complications, and finally we lost him. Uh, Subsequently, a couple of months later, we did a Whipple. Uh, on the first day after the Whipple, the drain showed about 400 ml of bile. Uh, I told the boys and I explained to them that last time we missed something, we went in late, and then we couldn't pull the patient. So today I'm going to re-explore this patient. I have a feeling there's something wrong with the anastomosis. There is somewhere there is a leak, and this much of bile it is not going to settle down. So we are going. I so on the so we had finished. By the time we had finished, it was about 4 o'clock in the evening the day before. So 10 o'clock in the morning, I took that patient above my routine list and re-explored her and gave a good wash. I redid the hepatic osteogenosmy completely. I undid it, freshened the edges, and redid the hepatic osteogenostomy, and came out. There was no leak after that, and she was discharged on the 9th, 10th day as any other patient was discharged. So in that we had a long discussion because the boys asked me, what made you go in on the second day, on the first post-op day itself in this patient? I said the lesson learned from the previous patient. I think this is what you must accept and tell them. Look, the previous patient, I think I made a mistake. I waited too long. This patient, I didn't want to make the same mistake. So I went in early. I knew that looking only at a bile, it's probably a biliary leak, but it could be something else. But anyway, I decided to explore. I've redone it, and she has had a smooth post-operative course, no other complication. Therefore, I told them that the previous case taught me something, and I implemented it here. Now, I think that every postgraduate and every junior consultant to me who was working there was surprised by my decision. But after the thing, they all came and said, we think you made the right decision, and we have all learned. Some of them came and expressed that they had learned something so important there. So I think that, you should explain yourself when you take a decision and why you're doing it, and not be afraid to accept that you made a mistake previously. You want to rectify this in this case, and then they will learn that. That group of people will learn. They will teach it to their students, and that mistake will be henceforth not fatal to patients. So I think it is very important to accept your mistakes and to tell them that you made a mistake and therefore you rectified it.
So I feel that you should have sessions more than seminars and all. Some of the sessions which help is surgical treatment planning, so that they are able to plan the treatment, and we see that. And subsequently, debriefing after surgery or the next day morning, that how the surgery went and whether anything, a change of plan had to be executed and why. I think if we incorporate this in the sessions, perhaps we'll be able to get them a little more
So
insight
that is
into
what I
what is
said,
the
that
decision
every
making.
morning we have this. The session
Yeah,
lasts about 45 minutes,
yeah.
and so but then cumulative over 3 years, it's a huge amount of cross of knowledge. So
So the
makes a
next
difference.
point which I want to come to is the important thing which every uh, student of surgery thinks, which is hands-on surgery. So how do you give hands-on experience to your trainees? What is the consideration in that? How do you escalate this? And I want to say this specifically because both of you also work in a corporate setup wherein patient expectations, litigation, all these are always on the horizon. So how do you do this, the hands-on part?
Well, how I do it is that the hospital has allowed us to do free cases, to do concessional cases. So whenever we have a free case or a concessional case, I tend to hand it to my postgraduates with one of the consultants assisting them or supervising them, and they will do it. Now, the type of
Why
case that
this
I will give them will.
discrimination?
Huh? Yeah,
Why this
but then that is the only way. You see, I in a private ward, the patient would have come and would have told me that I expect you to operate. In that case, I cannot break my word. I have to do it. Or I expect somebody comes and says Dr. Mohan has to operate. It will be Dr. Mohan. I will wait till he comes back and then give it to him because that is the patient wants him to operate. So there is no question that when the patient asks for a specific thing, we will give it. But then many patients walk in, and what we want to ensure is that we will not have any damage, and that we ensure that the case is given according to the level of skill of the trainee. So I get very raw trainees, so I have to teach them from how to open an abdomen and how to do a GJ, then progress in a DNB GI surgery to doing how to doing a Whipple in 3 years. So I have to take them from a very raw stage, which means that the first 3 years they were not given any hands-on, which is
So,
sad.
Ramesh, Hariharan?
Yeah, before I answer that, I was going to just make a short remark about the having an anecdotal response to decision making. Sometimes you go one way, and then the next case you become more careful. That is a good example, but sometimes I found that one of the most important rules that I apply to my own career and to my trainees' career is that if you have a clinical problem, or if you have a research problem, if you have a preparation for a topic problem, you have to consult another person. If you use another person as a bouncing board, you will always find that you may not even get answers, but as you voice your problems, you will find clarity emerging. And then you will find that you've got much more going for you by the time you've actually finished talking. And even though your companion does not give you much, you say, okay, well, I think I kind of figured it. So coming back to examples, I don't have enjoy the Ardhanari approach of the free and the concessional patients, and I am really rapidly against the fee structure. As a third year student, I watched an elderly lady undergoing telescopic tests for fractured neck of femurs repeatedly by several of my fellow students, and while she was screaming in agony, and I swore I would never make a difference between the governor of the state and the common man, and thank God I've been able to do that all my life. So in our department, patients are told that the operation is never the responsibility of a single person. That alone, I would never be able to get any of these patients across the line. That there is teamwork involved in patient, you know, appointments, patients, preoperative preparation. Our chief resident or the final year resident sees every case which is coming for surgery the next day. He's actually he or she is the devil's advocate. They are encouraged to create as much havoc as they can, in the sense they bring up all kinds of from the most trivial, such that somebody has missed out on a clopidogrel history, which is very, very life saving, and which is unfortunately the super consultants have failed to pick up, to the most technical issues, which leads to a change in the strategy altogether. Next day, the patient doesn't come on the list. Instead, the patient goes for radiation or something else. So this encouragement of insurgency, as I call it, allows residents to, in the pre-ops, and now we've got a pre-op WhatsApp group where they have to express their detailed assessment. If this is, if, in any case, all of us, even if we can't drive a nail into the wall, we look around for help. And this is the most important part of healthcare that we fail to take care. Most important part of teaching also that we fail to take care, because several of us have skills in several different areas, and we sometimes fail to put it together. So we have to, and I would like to encourage my mentees or myself to always consult a companion, a group, and that really makes for the difference.
What about hands-on training?
Our residents do paid patients, and there's no issues there. Because by the time they get to operate, they're as competent as I am, I would like to say. And more importantly, the most important thing I ask of them is only commitment. I ask them to be careful, to go stepwise, and if they have trouble, they must not hesitate to reach out to the next level of people. And if they do that, I'm quite happy to just step back a little bit and give them the freedom to operate without the pestilential presence of a senior all the time hovering over their right shoulder. So this is worked very well for me. I'm very clear that I've created more complications than my residents have in my career. Therefore, there's no conscience problem in this respect. And Sadiq is smiling because he's seen me making some of those complications, I'm sure.
So,
Sadiq, I also believe that you need not give a full case to a resident.
I was coming
So,
to that.
so,
Like,
so we can start. Yeah. So when they come in their first year, we look at their level. So we are doing a Whipple, for example, or a pancreaticojejunostomy for a phrase. We would give them the jejunojejunostomy and the
cholecystectomy.
yeah, if it is required, we will give that to them. Whereas once they are experienced, we allow them to do the phrase completely, including doing the pancreaticojejuno anastomosis, the head coring, and everything, and we watch them in the final year. So I think in a Whipple, giving the jejunostomy or giving the hepaticojejunostomy, in the second year, we give them most of them the hepaticojejunostomy, especially if it's a wide, nice bile duct. Then they do it competently. They have assisted enough and they have done it. Once they have reached a more higher level, then we give them the resection and the pancreatic anastomosis also. It's the pancreatic anastomosis which I give last, because that is considered the Achilles heel of the Whipple's operation. So we do that, and most of my consultants also do the same thing, and they allow the juniors to do much of the work. So doing an incision hernia repair, the senior may just go mobilize and then tell them, put the mesh, put this and that, and come out, and the juniors will do it. We also train.
Is there a difference between various people who are working with you? That to some
Yes.
they'll get some more than others, and that
Yeah, sometimes
decision,
it does
how do
happen.
you,
Yeah, so
based on competence?
obviously, in surgery is like any manual skill. There are levels of manual skill. If you've read Frederick Fawcett's novel, in that he describes the types of skill. He says that you have the good, then you have the brilliant, but above and all, you have the natural.
Natural.
So the natural is the one who is the most gifted. That is the Tendulkars and the Laras. So them you don't have to teach much. They just pick it up. But then the good needs to be given, that how to hold the holder. See, in their MS, if they come for their super specialty, nobody has ever even taught them how the forceps should be held, how should the needle be held, how you avoid taking the needle with your hand. I've seen many of them trying to take the needle with the hand because that's how they've been trained. And I tell them that this is a way to get injuries. Avoid it. Take the forceps and learn. You will also become more adept at using the forceps. So I have to teach them these small things. We also have residents from general surgery who rotate through our department, and there we teach them very basic things, and how to cut, how to sew, how to hold the holders, how to hold the things, what holders to see. Nobody ever taught us what are the different types of holders. What is a Mayo Hagar holder? What is a Renault holder? Or
I
what is the
found that while teaching and giving the sort of hands-on, it requires a tremendous amount of patience on the part of the teacher. Do you agree with
It
that?
does. It does. It does. And I think if you don't want to have that patience, don't be a teacher. Don't conduct a course just to get work out of people. If you conduct a course, you have to give them something in return to all the work that they do. And that is the training that they expect to get. And I think that is very important. Now, what happens is that you have the occasional resident who will refuse to work. We get repeated complaints from the nurses that they call them for the patient is sick. They refuse to answer the phone. They refuse to come. We pull them up once, twice, thrice. After that, there's no point. They just don't change. Then I don't give them cutting chances. I'm sorry. You have to. You will be forever an assistant, and your colleague who has joined with you, works hard, comes for every call that is called, and sees the emergencies. He will get to do a whipple and a phrase. You will not get to do anything at all, maybe. So I make it very clear that I expect them to work sincerely.
I, I, yeah, Ramesh, you
Yeah,
want
I
to
just
say?
wanted to the natural talent is great, but my observation is that it's often somebody who has a fair amount of natural talent, but who's backs it up by a lot of perseverance, who really becomes the Superman, in my opinion. Because many people with natural talent don't really, because it comes easily to them, they don't struggle enough. I think I'm obsessed with the fact that genius is 99% perspiration. And I really think all of my colleagues who perspired more in the process of learning, actually they got more skills from others. Not just I've personally I've learned so much from my own assistants, because some of them give you ideas when you operate, and then
Yeah.
you operate it, and that becomes a part and parcel of your further program. And I call it usually by their names. And when for a year or two I don't get enough such inputs from others, and I lament the fact that, oh, what's happening to this world. So I think we need to it's a very complex process.
It's very
A
complex. It's very
can pour the water, but the vessel that takes the water must be large enough to hold it. You mustn't pour the water too fast, or at the optimal speed. The vessel must not have holes and mustn't absorb the water, and must absorb the water without just letting it evaporate. It's very complex, and I think there's some providence as well in this process? I mean, whether you're
I,
going to
I
be
tell most of the people that be like a sponge, that you absorb everything around you, take everything which is there, and then later you can decide what to keep and not to keep. And observing things is very critical in operating theater. I mean, I think a lot of people forget that doing is not the only way to learn surgery, but observing how each step is done, how it is being conducted, planned, and executed. If you observe these carefully, you would be able to do most of the operations if your basic techniques
Yeah,
are.
that's how we learned because
Oh.
by observation more than by actual doing. Though I
I,
did a lot of surgery in aims.
I want to address two more
I
things
just want to mention two things.
before
One is
before we finish because it's 8 minutes, at least 1 hour time.
Right.
Then half an hour we'll ask Vidya what to do. There are a lot of new technologies which are coming in uh, every day. So there's a new equipment, new energy device, new dissection device, and then platforms like robotic and all. So how do we, as surgical tutors, uh, how do we go about getting into this, training ourselves, and also imparting training to this?
I
What
think I think that you must be open to new technology and to new techniques. I'm sure all of you will recall that along with Palnivelu, I was one of the sort of surgical gastroenterologists who took up laparoscopy very early. Most of the others were general surgeons who took up laparoscopy. But as surgical gastroenterologists, we were the two who took it up early, and we went into doing malignancies and advanced procedures much earlier than I did my first lap APR in 1995.
How
That
do
is 30
you
years ago.
suggest one should go about it in
I
the
think I
process?
think you have to attend meetings first and foremost. So how did I learn about laparoscopy? In 1991 or 92, there was a meeting between the Joint College of the Royal College of Surgeons and the Association of Surgeons of India in Delhi. And in that meeting, there was one hall where there were just 10 chairs. There was a TV and there was a VCR. And they were, I went there, what is this going on here? And I saw this, the gallbladder is being seen on the whole screen and some instruments are dissecting it. So I sat there very interestedly. I had read about laparoscopic cholecystectomy, so I knew this was there. And it was a surgeon from Madurai who was there. He was in Florida at that time. M.Y. Shankar was his name. And he was showing how to do it with a laser machine. And there were other videos on lap chole. And that is when I found that this was a very good technology. I came back, I talked to my chairman, and it took me about 6 months, 9 months to convince him, but then we got the instruments and then we started lab in 92 July. So uh, shortly after that meeting. So attending meetings is very important. That is where you will see new technologies, new things. Attended the meeting in 95 in All India Institute, and there for the first time the harmonic scalpel was demonstrated. And in 97, as soon as it came, I was the first person in the country to buy the harmonic
You should
scalpel.
be open to new technologies.
Yeah,
Get
you
yourself.
have to be open
Ramesh,
and
what,
see what
what
is
is
the
your thought
future.
on this?
Dr. Sadiq, there's one counter question here because one of the students has asked that how to impregnate new surgical technology to a student when the teacher himself has no experience in that.
So that's why I'm bringing this because first the teacher has to learn how would they go about it and how would they impart it. So
Yeah,
Ramesh,
that's right. So once you,
Hariharan,
yeah, yeah.
Yeah, I think Ramesh is right. We need to imbibe new technology, but also uh, show people that you will apply it in the right, setting and in the right manner, not just hit everything with one hammer. To appreciate that all of these technologies come with a price. They have their advantages. What are the goals of our surgical treatment? We must never fail to see the goals. We should not, the path itself is not also important, but the goals are also important. When you are talk about survival, sometimes so you need to put all these things together, but you must have, it is important to have teamwork, because I think in today's day and age, in Sadiq will know, in our own unit, different surgeons have different technical expertise, but teaching can be done by everybody. But surgical expertise may have to be concentrated in certain quarters, because one can't be an expert in or a master, as others would put it, in every sphere. So you need to be able to have different people in a team who can actually concentrate on different areas, acquire larger skills. There may be a Ramesh Ardhanari and there may be a Parinivelu, but there are not going to be many more such entities. So it's very important to be pragmatic. We also need to provide what are we training our mentees for? What is our goal? Our goal is to give them, as Dr. Anandakrishnan said, Dr. Nandyanti said, you said, and maybe I said it or not, but we all need to give them a rounded knowledge and a rounded perspective in the field of gastrointestinal surgery. So if all of us don't perform in every sphere of GI surgery, we must be happy to send them across to other centers to get training and give them exposure.
That's my
Sadiq,
question, Ramesh. So that's
Sadiq, I have got one. I have got an answer to that. Now, when in '97 I got the harmonic scalpel. Okay, so I started using it for everything, but then when I got my dip and B students, I would teach them how to do the cholecystectomy or the appendectomy with a monopolar and a bipolar. Because I was not sure that when they go out, they will have a harmonic scalpel. If I teach them with a harmonic scalpel, they may not be able to get that, and then they may struggle with not having done with monopolar and bipolar. So I would insist that they do it. But then now we don't do that, because we know that every hospital they go to, they will have a harmonic scalpel. They can do the things with the harmonic scalpel. So we allow them to do the procedures with the harmonic scalpel. So I think we also evolve with time with the technology. As the technology ages, we allow our postgraduates to use that technology so that they can progress. So I would not allow them to use.
point which I wanted to bring forth, both of what you're saying, is that is there a role of multiple teachers? Like,
Yeah.
as we said, research is a component, and not necessarily everyone can be able to guide a person for research. The second thing is some new procedure or technology. So do we encourage our students to keep on updating their knowledge and
Yes,
skills by
they must be
listening
allowed to
to
attend
our
conferences.
experts in that
Yeah, they
in the
should attend
course of the
conferences.
training?
Yeah, they must attend conferences so that they can see different people speaking, different technology being demonstrated, different operations being demonstrated, and they will take heart from some of that and maybe become an expert at that. Uh, Whatever we lack, we must send them out. For example, for a long time, we were not doing liver transplant. So I would send them to Medanta or to Subhash Gupta for a month or 2 months, depending on their interest, for training there. So they would be given full salary here, but they would go and train there and come back, because we were not doing. Now we are doing, so they're getting enough exposure, so they don't go. So similarly, I found some people coming for laparoscopic training from other centers where they were not doing so much of advanced lab to see lab, and they learned, and then they went out and they are now doing very well with lab. So I think we have to encourage them to go out if there is a thing that we don't do. And I think every hospital will have some deficiencies. And it is time that we understood what are the areas where we are deficient, and we try to show them those areas in different by sending them somewhere else.
So let me come to another aspect of surgical training, which is the non-technical skills for surgeons. Now, there's a lot of talk about this. I believe that we impart this in any case to our students, but do we need to concentrate more on that? And from non technical skills, I mean skills of communication, skills of leadership, skills of how to run a team, how to make sure that the situation which you are encountered with, you are able to deal with successfully. So, what are your thoughts on this?
I take the question.
Yeah, Ramesh.
I think I don't think you can teach it by doing a course. I think you have to borrow Dr. AK's phrase of walking the talk as well as leading by example. So if you are able to, in the most trying of situations, perform with exceptional non-technical skill, then that is exactly as inspiring as how you would deal with a intraoperative complication in a calm, systematic, organized manner, get help, get the best situations, and then deal with it effectively. So the same thing should happen in terms of non-technical skills as well. And I for one think that you can't really teach it in the classroom. You have to show them by example.
But Ramesh, we have seen that one of the things lacking when we look at medical education and surgical education is A, communication, and B, interaction on non, medical issues with the patients. So, I mean, unless we teach this, how are we going to?
Sadiq, I must, place on record here the fact that in any average medical college in this country, you don't actually take permission from the patient to examine the patient.
Exactly.
The teacher never introduces the students to the patient and say that this is part of their curriculum. They are not going to hurt you. They're going to inconvenience you in a minor way, but they are going to be the future me and the future everybody else. So you do show them some, consideration. And if they're having a bad day, that's not the time for us to, send them for clinical examinations. We have just forgotten all about that altogether until this plethora of private medical colleges came when the patients became unavailable. Then teaching has become by the classroom with videos and with images. So this is a problem that hospitals who want to be teaching hospitals will have to struggle but achieve it. They have to set up their system by telling. I tend to tell my patients that the reason my patients do well is because I've got such a committed set of youngsters who are raring to go, who are very, very irreverent in a way because they don't just follow, they don't hero worship as Dr. Nandi said. They're far from it. They are very critical and they lose no opportunity to disagree, and who are potentially the leaders of tomorrow. And if I do not, as in management, they say you empower people and you show trust, and they generally don't let you down. If you, on the other hand, if you say, oh, he can't do it, and then you send somebody to run an errand, he or she will never do it. So I feel that it has to be done, implemented in basic medical education, not in the classroom again. Classroom, I think we've had too much classroom, and in that sense, I agree with Dr. Nandi that we get too much classroom stuff. The patient is the best, encyclopedia that you can. I think we should all thank our patients first because they are the ones who have allowed us to participate in this session and to actually give vent to our thoughts. But for their, tolerance and their, I think their forgiving nature, many of us would not even be here today. So I think we can't do this in the classroom. We have to do it in the ward, in the clinics. We have to talk to patients.
So it has to be done, right? So these are important components of this thing. So I think we are coming towards the end, and I want to ask both of you one by one that what do you think we all should do as teachers to improve the way we impart surgical education?
I would like to bring up a new point here. The thing is that in the MCI, you don't have an opportunity to refuse seats. They say you have four, we are making it eight, and eight it is. You can't refuse. But in the national board, you can ask the national board that I will only train so many students, and when they, even if the inspector recommends more, you can say no. So since 2009, I've had inspectors who have been recommending 4 seats per year in our hospital, and I have refused and I have kept it at only 2 seats per year. And the reason I believe is that I can train 2 students per year, which means 6 at any time, well, but I cannot train 4, which means 12 at any time, that well. I can't give them hands on, I can't give them enough assisting opportunities. And so I have curtailed it. But many other departments I feel are very greedy. The moment he says, I'll give 4, they immediately want all 4. And
So
they are
you mean
not
to
even
say
able to
do justice to the students or people?
student. You must
That is one.
introspect and say how
Anything
many
else?
can I teach.
Anything else?
No, I think the rest is the same. We have already discussed.
Ramesh,
So
Ramesh,
I think in 1989, I participated in a debate in Madras where I think Sitaram and several other friends were present as to whether we needed a qualification. And I criticized it excessively in spite of the fact that I was one of the earlier ones to get an MCH. I said, we have now a huge conundrum that we have so many qualified, but so many perhaps less than competent human beings. And also, we have many people who don't have the qualification, but who are super competent. And the system has completely failed. And we have now subdivisions. So, gastroenterology surgery is no longer an entity. It's already been sort of eaten away by different specialties. And so, my trainee is completely torn by a million, dilemmas as to which aspect of this he or she must take up. And this is where I think the Medical Council of India must, at some time, they have to do away with the exit exam and the entrance exam, but do competency based training. And then, therefore, in that case, I would have a very uh, uh, a private, a confidential portfolio, which I will, if I were going to Madurai Meenakshi Hospital for recruitment, I would let them access my portfolio. They would know whether I knew how to put chest tubes, whether I knew how to do, minimally invasive thoracoscopic surgery, or whether I didn't know that. So everything would be very clear. They had a clear idea of what is the type of product they are getting, and then they could sort of slot me into the correct stores. Today, the biggest problem that has for trainees and for trainers is getting into the right place. Very many of them have so many skills, but that's of no use in the place where they are working. And that's because of this failure to understand, if I have an MCH, I need to have all of these. Not necessarily. We may not have any or all of these. So we need some system in this large country where we can clearly say, this is what I know. It's not a shame not to know so more. It's not. It's great if you know a few things, but very well. And I can definitely teach that, impart that to the next generation. So I think I'd like to have. If I'm using the last word, knowledge is like a meal. You can never feed people enough. And I think when I die, I would like to have, you know, given away all that is in my head, and all the, if I have accumulated some wisdom, to be able to have given it all, so that there is no use where I'm going, isn't it? So I think we need to share knowledge. We need to see that, people receive it, get them into the right mood to receive it. Sometimes it's not just done by donating so many rupees to child relief, and you have to actually make it work on the ground. So it's a lot of effort. It often does not pay fruit. As Dr. Ananthakrishnan said, some of them will be frustrating, and some of them will just not see eye to eye with you. Ramesh Ardhanari said about people who just don't care, and you can't do a damn thing about it. But nevertheless, the next candidate may be a shining example of all that you expect to stand for.
So just
But Sadiq, I am
Ramesh,
not with
equally,
I'm
one
not
last
with
question.
Ramesh. I'm not with H. Ramesh on this selection business based on competency, because I have seen what happens whenever you have a selection where four interviewers are sitting and where the political system has a say in it. That good candidates are usually rejected, and only those who got the pull and the push, they get selected. I am for the entrance exams. The exit exams also, I think, just test your competency, and now they become quite fair. It is not like it was in the past. I think you need something to know that the person is fairly competent, and I think that we can judge. So I
Dr.
think
Vidya wants to make a comment, and she has the floor. She's the organizer and coordinator. And
No, sir. Thank you. No, I was just, I thought maybe we should start taking the questions and comments on the chat box. So, one of the first ones which came up is uh, how the principles of teaching surgery have changed in this era of technology and technical advances. Has it changed, and if so,
has
how?
it changed? Ramesh, Harrier.
Not really change. The fundamental principles remain the same, because you have to cut tissue and you have to stitch tissue. Now, the way you do that has changed, and you will see in your own institutions different techniques. There are still some people who ligate every structure and divide it, and then there are people like me who use the vessel sealing devices for sealing every vessel, excepting maybe the named ones like the left gastric or the hepatic in some cases.
So
I would see. So it will vary, but otherwise, I think the fundamental principles remain the same.
How things have
I
No
changed?
feel
tension.
I
How
feel it has
uh,
changed.
how things
Uh,
have changed
there are a
dramatically is
lot of
that sorry.
Dr. Sadiq, Dr. Anantkrishnan wants to say something before
yeah.
we go on with. Sir, can you unmute?
No, I can wait for them to finish the chat box, and then if you have time, I'll say it.
No, so, any of the points that are being raised, we'd like to hear from you also, sir. Given, okay, let me just add another twist to it. Ravi is, of course, only saying has it changed because of technology and technical advances. I'm saying you throw in the fact that there are a lot more of medical colleges, more students, and less patients. So, in this combination, uh, the principles of teaching, meaning we are not talking about principles of surgery, but how it is being taught. For that, does it need a paradigm shift at this point?
No, Vidya, first of all, how rounds have changed nowadays is earlier we used to have, questions sometimes posed to mentees and they would answer them or fail to answer them. Now, if there's a large group, several of them at the back simply Google it and give you the answer. So, data information is available to everybody. Now it's more a question of choosing the right information for the right patient. And so I think, for example, if I see a somewhat rare case, I often say I have to read about it before I even decide. So I think examinations must also change, that we need more information on strategy building rather than how many causes of dysphagia do they know, that is available in Google Glass and the AI Chat GPT and so many other sources. So we have to change the system. There is so much change happening. That's a fact. And I agree with Sadiq on
And
that.
and also the clinical relevance of examination and the things has come down, because we now have access to so many investigations which tell us everything in detail. So we also have to teach that to our students so that they know how to interpret a CT scan, an MRI scan, and then use that information to guide them in operation. We didn't have that in our training, but we have learned it over the years, and we have a duty to teach that to our students so that they can uh,
No,
use it.
Ramesh,
I feel the
during my
way,
during my
may I just take a point, Ramesh? I
during my
feel, Vidya, the way it has changed, in my opinion, is that at our time or earlier, we were always looking for information and absorbing it, because the sources of information were limited. It was a tedious process to get all the information in the library, searching through all the things. What I feel now is the information is easily available, and that makes them a little, what should I say, uh, unresponsive to discussions, because they always feel that we can get this information, as Ramesh said, Googling it at any time that we want. So not necessarily you imbibe what is being discussed, because it is a specific situation that you are discussing, which you may not get by Googling at all times. So I think the change is better for the availability of information, but for application of that information, you still need to interact, which that interaction is becoming very, very superficial these days.
So if I could just flip it the other way, okay, we have talked about knowledge. What about skills? Do we need to change the way we are imparting skills today?
Yeah,
We need
yes.
to.
See, since you want your patients to have the best of care, we must start using the animal models of training. For example, Ethicon runs a 2-day vascular suturing course, intestinal suturing course. They can attend that, and they will become technically competent at doing the. And then when they come to the patient, they already have some background information. So we must be able to use these in more. The problem is that these courses are expensive. They cost 25,000 or 30,000 rupees. PGs are reluctant to spend upon it. Uh, but I think that they should be encouraged and they should be told, no, you have to do this, and it should be part of the curriculum. And I think they get good enough salaries to afford these, and they should be asked to go and do these things. And so I try to organize some of these courses once a year in our own hospital, by using my good offices with some of these companies, and they get a free training. But not all, I cannot do everything. Some of them, they have to go to the lab, because only there they can actually get a good hands-on training. And some of these trainings are excellent, so they can benefit from that.
So, Dr. Anandkrishnan, could you get some perspective on the MS training? I think because all three of them are surgical gastroenterologists, the entire discussion has been surrounding super specialty or surgical gastro training. But
No, I'm sorry. Much of my discussion was on general surgeons. I was talking about how to do an anastomosis, how to open the abdomen has to be taught. So the teaching, I was talking of both postgraduate and super specialty, but I was talking mainly of postgraduate, because that is the foundation. Without that foundation, the super specialty cannot be built, as we have seen, depending on the type of student that we get from where he is trained.
so, you may not have a solution, but there is a person who has said, "Sir, I study in a government institute with really good patient load, but still faculty is not keen on teaching anything, and faculty is doing all the cases with minimal hands-on to the residents, with blaming every complication on the PGs. Plus, there is discrimination between PGs just because few are outsiders in spite of skills and knowledge." How to deal with this, sir? I don't know if any of you have got a answer to this, but somebody has really spoken that how to.
This cannot be cured. I will tell you a very short anecdote. I was at a party, and it was a party of surgeons, about 7 surgeons, out of whom one in Madurai was particularly known for being a brilliant teacher who would teach hands-on to all his things, who would go out into private practice and assist his PGs into doing, as after they had qualified to do the cases. The Everybody got drunk. I don't take alcohol, so I was just listening to it. The other 6 jumped on him and said, "You are spoiling the students, you are teaching them, you are making them our competitors." See, this feeling runs in many of the teaching hospitals, that the teachers feel that the students are going to be tomorrow their competitors, and therefore don't teach them. But I can tell you that these people don't deserve to be in a teaching hospital. If you didn't want to teach, why did you go there? Just to get cases which you can siphon to your private practice. I think this is a big problem, and I completely agree that many government hospitals this happens.
There's also another question on the other side. These days, we get residents who wish to get a degree without going through the mandatory grind like we had in our days. How to deal with them? I know, Dr. Ramesh Ardhanari, you said you don't give them cutting chance, but is there some other way anyone else wants to take that point? Because I think it's not necessarily only in surgery; it could be in any specialty.
Yeah, so, so it's becoming more and more difficult because the entrance to these courses is through a theoretical test, and there is no competency assessment on that. And once they come, they have to go through the period and clear the examination, and then you get the degree. And I often feel that a significant proportion of people, I'm afraid that they're getting that designation of a super specialist after that 3 years. So I think there should be some way that you would say that these are not fit to get into the super specialty. I'm talking of super specialty specifically. Or you have to have a way that they would exit out of this only when they are competent enough to deal with most of the situations.
Like any of you believe that simulators and virtual reality and all is going to be
That's what I was saying. The courses, the simulators, virtual reality, I think they all make training much easier. Now we have such real lifelike simulations that they can actually do a nice cholecystectomy, appendicectomy, gastrectomy but these systems are expensive. I have not been able to convince my hospital to buy something that costs 65, 70 lakhs for training for students. So we use the old pelvic trainers with the cameras, old cameras.
Simulators which I have seen, they are awful actually. And to be very honest, in those simulators, I can't do a cholecystectomy without
No,
injury.
you must. So you have to buy these expensive simulators. The ones that really have good thing, but they are very expensive. No private hospital will spend on it. We do have government hospitals that are now going into it now. Both JIPMER, I think, and PGI, and even AIMS, I think they have the robots which have both two modules, so that one the trainer can sit, one the trainee can sit, and then he can be guided through the
robotic assisted training. Yeah.
So, Professor Anandakrishnan, your institute has one of the state-of-the-art simulation labs. Do you see it being used? It's very expensive. Everything has been bought, but is it being used, and is it translating to good training or skills?
Okay, Vidya. Now that you've asked, I'll answer that and raise one or two issues more, which I think we have not dealt with adequately. See, the number of postgraduates in JIPMER when I was head of the department was 6 per year, making a total of 18 altogether, putting 3 years together. Now they have 75 postgraduates in surgery. And the workload has not increased proportionately to that much. So the hands-on has necessarily come down, even in centers which are very, very busy like JIPMER. And if you take private institutions like ours, we have 18 postgraduate students per year, making a total of 54. So simulations, animal models have become mandatory. There is no going away from the fact we have to get used to these crowds because we are not in a position to control the admissions. The policies are made elsewhere. That's number one. Therefore, we need to have high fidelity simulators, which may not be the actual experience, but fairly good experience as an initial step before they get actually hands-on experience on real patients. That's number one that we cannot run away. The second point I wanted to make, which has not come out very well, is that the hospitals are not holiday homes. They are not the most pleasant of places where one would like to go and spend spare time. So those who come there are forced to come there. They are under a lot of stress, as are their relatives. And therefore, the importance of communication has to be positively enforced. It cannot be left only to them for watching the unit chief, but it has to be positively enforced. And we are not doing that because if you remember, all of you will know, most of the conflicts in the public between patients and healthcare providers is over communication. And therefore, and I disagree with both the Rameshes that soft skills cannot be taught. They have to be just mentored and imbibed. No, we can teach. There are very good.
I didn't say that, sir. Sorry, I didn't say that. I said
Maybe
it can be taught.
Ramesh Hariharan said it.
Not in the classroom, I said, not in the classroom.
So no, in the classroom you can teach. There are very good courses for doing that. And what we have to learn is not to be impatient because their level of understanding is not the same as ours, and therefore we have to put ourselves in that. That's the second thing. The third thing is surgery is fortunately for us a very rational subject. There is a reason for everything. If you know the reason, you will remember. If you don't know the reason, you have to learn it by heart. You will not remember. Therefore, it is our duty to create a spirit of inquisitiveness and encourage questioning, solicit questions, which we don't have patience to do. And they are afraid to ask because the whole career till then in school and in MBBS, they have not been encouraged to question and therefore they are a little hesitant. So initially it will be like that, but if you create an atmosphere of trust and trustworthiness, I think they will ask. And if they don't ask, you raise the issues and ask them to respond. Because once you give the answer with the reason, then they will always remember that. That's the second. The third point, which did not come out, is I see a lot of posts in learning general surgery, young surgeon, where can I go to get more cutting? Now that phrase annoys me terribly. I don't know why, because as a surgeon from 1973, 50 years over, I don't think surgery is cutting. That is the time when we were all barbers. But surgery is not cutting. Surgery has a lot of pre-operative work, a lot of post-operative work, which together give the results, not the cutting part. And therefore, I think from younger days, we should discourage them from falling into the trap that surgery equals cutting. And unless we tell
But
them,
if I may interrupt you there just and ask you a question, sir.
you ask me after you finish. The
After you
problem
finish, okay. I'll ask you after you finish, okay.
Yeah. I'll answer all your questions with the best of my ability if I can. But there have been many instances where you asked me and I have not been able to answer in, in conferences. Maybe today will be one more, Ramesh. And the third is you also have to draw the line beyond which they cannot transgress. And that requires a little bit of strictness and a little bit of discipline. Because once you allow them leeway to cross that line, then to get them back on the safe side is very difficult. And that becomes mandatory. And the odd examples that you quote about the attitude of surgeons and chiefs and competitiveness and all that, they're not the rule. Even in the corporate sector, I don't think it's the rule. And in the teaching sector, they're certainly not the rule that you are jealous of your students because they develop skills. I have not met anybody on 16th of December.
Unless they are under the influence of alcohol, they won't tell it, sir.
As like you, I have never been under the influence of alcohol. So
So both of us are
I
so
don't
so we
understand.
are open, but and we both are teachers. So we give our chances. So we know what we are. But I did tell you what was
And
my.
the last thing before I stop and allow you to ask is, you have to take ownership of events which don't go well. If you start finding people to blame, then your residents will never trust you. And therefore, you have to be big enough to take ownership of decisions which always don't end up very satisfactorily. If you follow that, I think by and large, units work cohesively and a lot of learning happens. Now, Ramesh, you are open to all your questions.
No, my
But I
question
don't
was
know why
very.
you are the
It was very.
target, Ramesh Hariharan, and
No,
why
no,
I
no,
have to answer all the questions.
no, because no,
Is it
because you made
permitted,
a
Sadiq?
point. No, you made a point that they put this statement about cutting, but then
Yeah.
surgery, to a large extent,
No, it's not.
the main
I don't
part
think there is a
is
lot.
the operation.
I,
And if you find an MS postgraduate coming out who has never even done a laparotomy or an appendectomy, don't you think that that is
I
not correct?
never said cutting is not part of surgery. I said cutting is not the only part of surgery. Where
I
can
agree
it
with
go
you,
to?
but it's an important part. And
Language used
but
is unacceptable to me because
I have
you
had
can be the best
people who
cutter
have
in the world.
completed MCH in private hospitals and come and trained with me saying they have never even done a laparotomy
That's okay,
in
but
their
that
life.
system is at
That
fault.
because so it is not their fault. It is because the courses have been approved, but nobody has audited the courses, and the fact that nobody is being taught is not being seen, and the renewals are given automatically. Everything is just money. It is, you see, if they had audited the students who passed and asked them, what did you do? How much have you done? And then said, look, you are unfit to train, and therefore we'll stop it. I've never seen an institute being stopped because they are unfit to train.
My life, Ramesh, many times the decision not to operate is as important as the decision to operate. So,
Absolutely right. You're
in,
absolutely right. That I do agree.
in my mind, surgery never equals operation or cutting. It can never be.
So,
But it has a percentage which is there for cutting is there, and that percentage, I think all of us would like it to be a small but significant percentage. And if you have a training
That is
without
granted,
any
Ramesh. That
cutting,
is granted.
so
Some
can I
people,
can I just
No,
respond to the
that is
teacher?
the rant that our student had. Somebody had posted that they are not being. I mean, in the end of the day, if you don't know how to operate and you're a surgeon, that's you're probably not. You could be theoretically brilliant at preoperative evaluation and post-op, but if you never got to operate, then that would not be a good place to be for a surgical trainee. So, both your points are well taken. Just for light-hearted, for a change, I think I have a strong feeling it's an anesthetist who's asking this question, though it's not really relevant to today's thing. How do we deal with arrogant fresh surgeons with inflated egos and pseudo confidence? Uh,
just ignore them.
why do you assume it's anesthetist? Even we all have the same problem with some of our
Just
students.
ignore those surgeons. That's all.
Yeah, that's all.
when you have to work with them, what do? You can't ignore.
But
Uh,
no, over 3 years, we can train them to be. They will come to know their actual abilities, and they will know what it is, and they will see, and then they will understand. And I think some of us were like that. I mean, I was probably a very arrogant surgeon when I was. Sadiq was my junior, so he knows I was probably a very arrogant surgeon. But I have mellowed in the years, and that happens to everybody.
Vidya, can I just raise a point?
Absolutely, absolutely.
In the PGI, there used to be a reputation that excellent training, but not real cutting, as use the phrase again. So we did a study. We got 10 residents to do an inguinal hernia, an operation they had assisted numerous times in their open inguinal hernia. This is probably 1981. And we told them that we are not going to do, we just observe you. If you're going wrong, we'll tell you. And we were astonished to find that several of them did not know exactly where to paint and how to drape. Whereas two or three could complete the entire operation. Two or three needed some help in terms of they managed to put the cord in the wrong place and things like that. So then I brought it. I gave a talk on it in the lecture theatre one, and I said, obviously there is a need to observe. And similarly, as a corollary to that, we had a resident who is now, I believe, in the UK, who who had actually become very good at doing fry procedures, and he used to do them, churn them out because once we found he was good at it, we were happy to let him do more and more. So one of the cases was particularly difficult, and for some reason I scrubbed, and I said, "Shall I assist you?" So he said, "I'd much rather watch you operate," because he said he felt he would pick up more finer nuances by watching me operate rather than by doing the surgery himself. So because he felt that he could put it into his dictionary. So I think observation is critical, and that can never be underemphasized. Of course, the surgeon must also employ broad principles.
Can I make a few points, Vidya?
Yes,
it
sir,
okay?
please. You're the
Yeah.
boss.
So, I mean, Dr. Anand Krishnan, you, as always, you brought out great points. Do you know that there are 13 MCH residents each year at SGPGIMS? 13 each year, which comes to 39 in 3 years. And I can't imagine that how they would be trained in such a large volume, even if it's a large volume center. The second thing, it's amazing that a person came to me for one of the choices for DNB was Sakra Hospital. And his first question, he sat across me and said, "How much cutting will I get here?" And I said, "I'm sorry, you are in the wrong place." So what I feel, as a teacher, what I feel is that A, you need to be unselfish and you need to be able to share as much as you can with your students. The point which I always feel important is that it's a two-way street. If teachers inspire students, teachers get inspired by students. If you have students who are committed, passionate, and are willing to learn, every teacher would be wanting to share all that they know with them. So it's a two-way street, and that should never be forgotten.
Yeah, Puneet, you
I
have
also
your hand
also
up.
I
Sorry.
also want Vidya to add one point. During my MS and during my senior residency days, I strongly believe that I learned as much by making a junior do the operation, even an operation which I had not done. So I remember I made somebody do a right hemicolectomy. I had not done a right hemicolectomy, but I had assisted on plenty. I was otherwise confident of doing the operation. I made him do the right hemicolectomy completely, including the anastomosis. I assisted him. But to me, that was as good as me doing it because so this is something that many teachers don't understand, that when you make somebody do, you are actually showing that you know everything about it. That is your confidence to that you can do that operation.
I see Puneet here, and I'm
Yes,
sure he has a lot of things to say.
yes, Puneet and then Ilango. Puneet, you
Puneet,
need to
you need to
unmute yourself.
unmute, Puneet.
Okay, hi, yeah. No, lovely discussion, I think, and very important. I'm actually feeling bad that it's a marvelous merit session rather than I put it in a lot of surgical groups, but I wish many more would have joined in. But I guess the YouTube will extend on to them. So I think what some of the faults we have is we are very hierarchical in our training. Other than the best, I find in some of the private centers, it's actually a little better because the mentor is directly training some of the mentees, which even though the load may be a little less, but there's much more personal involvement, and we don't have 39 trainees and things like that. So most of the government setups have, in those 39 and 75 numbers. It's the guy who's just 1 year senior who's actually helping them, or 2 years senior. Now, that, according to me, they're bad, the entire system, and we are perpetuating that bad thing. So, what I found in the Japanese system is it's the professors who are scrubbing up with the junior people, and there are enough studies to attest that there is absolutely no difference in complications if the person is sitting throughout. I've seen a lot of my peers who will say, oh, when a complication happens, that iPhone anonymous person actually put that very subtly in his message as well. And I realize this only now as my son is going through the training process, that there is a very quick thing to put the blame game on the trainee for everything. Like in my day, it used to be the anesthetist who was at fault for every anastomotic breakdown. They gave the reversal too quickly and things like that. So I think that bit is a little, bizarre that we are continuing with that. And what Ramesh said, Ardhanari said about retribution by the teacher. I'm not sure that's accurate, because the perceived sincerity by the teacher may be completely wrong. It might be, a person. What I feel is, as a trainer, particularly in surgery, in all specialties, it's different. From the difference between undergrad and postgrad is we need to read every student separately. Some are and personalize it. Some are sensitive and they run roughshod by our macho toxic masculinity of the surgeon, the extroverts who run roughshod over those competitive types, over these people. So I've seen a lot of people. You need to personalize it for every trainee. That's one thing we don't realize. And it's those ones who might be actually looking for the training elsewhere. I agree, observation is equally important, but I think it has to go pari passu with the cutting experience as well. So I like the example H.Ramesh gave about that. A phrase is so important, I think, because I think you learn much more after you've done it and then you see a game. I have learned so much, like Ramesh Ardhanari said, from conferences. I've shared rooms with Ramesh Ardhanari in meetings where, for some coincidence, I've always ended up sharing with him. And he, in the evening, he showed me a video, and I said, oh, wow, this is this muscle welding technique for the stopping the bleed, and so many other small things you pick up every day. So I think ghat ka pani, you drink, go to different places, as Sadiq was mentioning. I think it's amazing because people who've gone to multiple centers have done better. So I think we should encourage our kids to go to those places. And I think there's no doubts that those knots is completely translatable in the training process, and it becomes, in fact, you can train them to be second nature to them. If they actually imbibe them through part of a course. Watching a senior might be detrimental because sometimes they do not. We all like to imagine that, and none of our training systems actually look at the trainees' feedback, which is the first thing I need to. And we are not going to improve till we improve trainee feedback. And I'm sure Ilango is going to speak right after me, is going to emphasize all these points. Am I right, Ilango?
Thank you, sir. Thank you. I still feel that a good surgical teacher influences the student in many different ways. See, I worked with Dr.H.Ramesh in Lakeshore about 20 years ago, sir. 20 years ago, I was with him for a brief time, and there were lots of students with him. But the best thing I remember, he taught me during our rounds was how to organize my data, both my rounds as well as the information I gather. I think that was the biggest lesson I learned from him. I have carried it throughout my life. And then one day in a fit of anger, he said, I'm going to set all your butts on fire. And I want you to, that will take you to greater heights. I think he put us through a rigorous training. That also changed the way so I had nobody to put the fire in me after I left Lakeshore. So I tended to do it myself. So that was the influence. The other important thing, I have never worked with Professor Sadiq Sikora directly. But when I was in Lakeshore, there was a piece of paper in which he had taught somebody the protocol for total gastrectomy post-operative care. I have never worked with him I just saw a paper in which it is written SSS. So I asked who SSS is, and they told me it was Dr. Sikora. And that paper I took, and that was the foundation of how I wrote every post-operative protocol that I still follow, whether it is liver transplantation.
That's why it's missing from Lakeshore.
So the back room had a lot of protocols like that. So that's the influence. You carry it all. I mean, I can go along with Dr. Ramesh Ardhanari, or everybody has a story. So the idea is that I went all around trying to pick up the best from everybody. So that influence, I think, is something the students are not getting now, because they don't want to interact with the teachers. They don't want to spend the time. That's a sad process. It's a loss for both the teacher as well as the student. The other aspect I feel is encouragement. I think Dr. Humar, who trained me in transplantation in UPMC, he knew that I came to transplantation at quite a late age. I was 42 at that time. And when we started training, there were a lot of things I had to pick up. Technically, they found me competent, but I had to read a lot of background work, medicine, and stuff like that. So every Sunday, he would round with me, spend time with me, going through every aspect of transplant care. And some days he would just give instructions on the phone to do a surgery, a transplantation, renal transplantation, where the renal vein was transected at the hilum, and I was the fellow on the table. So he didn't come in. He just said, Ilango, you just can take the IVC and plug in and don't waste the kidney. And it worked. Every bit was encouragement. I think that actually gave me a lot of confidence to do transplants independently. I think that is one of the key aspects of a surgical teacher. These are what I feel makes a difference in the life of a student. Thank you.
Thanks. Radha, you wanted to say something?
Thank you, Vidya. Amazing discussion. I still, when I was a resident, I still remember being in Dr. Ananthakrishnan's and Dr. Smiles' operating room as an anesthesia resident. It was the most pleasant experience. Thank you, sir, for that. And I can tell you're Dr. Sarak Chandra's student, because I was in Madras. I did my MBBS in Madras Medical College, and I had the privilege of him being my teacher. And I remember him saying that a good surgeon is the one that knows when to keep the knife in his pocket. So it's not all. So surgery is not all about cutting. That's what I realized at the time. I really wanted to be a surgeon.
That could be dangerous if the knife cuts the testicular vessels.
So, anyway, so he was
not all surgeons are men, right? Sorry, not all surgeons are men.
Yes, that's thank you
more
for
kept,
pointing
more
that out.
kept their knives in their pockets, there would be even less men.
Okay, ignore it.
No, that's okay. And so I'm glad you brought up the point that there are a lot of women surgeons now too. Thank you for acknowledging that, and even in this day and age. And I wanted to be a surgeon because I really loved to do it. And then, but I had no background, I had no backup, but I wanted to be in the operating room setting, so I became an anesthesiologist. And even now, somebody talked about speed. Speed is not everything either, because and a surgeon not only has surgical skills, relative speed is important. So you have to be fast when you have to be, but you have to be slow and steady when you have to be. So I prefer those surgeons. And as far as arrogant surgeons, I still come across them, and I tell my residents and my nurse anesthetists, okay, this is your day to improve your FRC. Just keep taking deep breaths and do what's the right thing for the patient. That's all we are here for. We're here for the patient, and we just move on. We ignore the surgeon's ego. And great points by everybody. And ask for us, definitely ask the anesthesiologist who to go to, because skill levels for different things vary. So I do a lot of neuro, and so I know which surgeons are good with cerebellum, which surgeons are good with cerebral. I mean, cerebral, cerebellum is all the same, but then, who are good spine surgeons. And we have a specialist in our center who works only on insular tumors. Nobody else in the world does it as well as him, because he has gone to the animal lab and done a lot of anatomical dissection and found the approach. And so we get worldwide referrals for him, and I do awake craniotomies on those patients, keep them awake during the procedure so that their speech and motor are not, their quality of life is not affected by speech and motor. And so great points. Wonderful discussion, and thanks again, Vidya, for a very, very lively discussion. And luckily, I happened to be at home on a day off, so I was able to completely, participate in this without being knee deep in cases. Thank you.
And our last question to the panel again. What should be the attitude of a head towards residents, bossy or friendly? Which is better for learning?
Friendly most of the time, but when there has to be something that has to be said, which is absolutely essential, where they have gone wrong or they have done, at that time you have to be a boss and tell them this is not acceptable and this is what should have been done or should be done. And don't hold it against them. The most important thing is that if you keep plugging away at it for the next 6 months, they become so tell it and forget about it and be friendly the next day. Then they will take it well, and they will usually correct themselves.
Thank you, sir. Radha, we are running out of time, so I think high time you came in.
Yeah, I mean, as expected, with just such a wonderful discussion and listening to all this stalwarts, really wonderful. I had two little questions before we close. One is, I remember Ramesh Ardhanari commenting on that he will give more chances to people who do well and bigger, longer steps and so on. Now, when I was a medical student, the ones who are weak are given special classes. I'm sure even in surgical training, there are some who are not up to the mark. Do you take any extra effort to bring them to a certain level, or you just ignore them? If you ignore them, they'll be like that forever.
No, if they are hardworking and they are sincere and they want to learn, we will give them extra attention and make sure that they improve. I will do that. But then many of these don't want to work, and therefore they are laid back and they just want to just sit in the room. You have to call them to assist on the cases. Things like that turn the teacher off. So it is I will help them if they are interested in improving.
Would the other two, Dr. H.Ramesh and Dr. Sadiq, would you want to respond?
Rather, that point is very important. What I agree entirely with Ramesh, that you need to give special attention. But what I always want to see in the person is a commitment and a passion and the desire to improve and learn. Unless these components are there, I think it's very difficult to invest more time.
No, I have this I have this observation that often the ones who are careless and indifferent are very fast learners, unfortunately, and they don't need you to give them any special care. They're just indifferent because they don't want to go by the system of that department, and they are just the type of rebellious characters that they are. Once they sort of fall in place later on in their careers, they just become brilliant performers. So we all see people at snapshots of their career. They are often having personal lives as well. We have a lot of challenges. So I think we just take it as it comes. I mean, we should be ourselves. Each mentor is himself or herself. It's not they can't all be like a standard issue. Each one will have their own specific pluses and minuses, and that we have to do with that. We have to simply do with the pluses and minuses of the mentees as well, because they will be of all shapes and sizes, and we just have to make do with them. But I have seen times without number that some people I thought were absolutely no hopers. I never voiced it to anybody, but I told myself, oh my God, what's going to happen to these staffs? They have turned out to be such shining examples of ethics and upstanding character and very good practice, as volume of practice, good outcomes, and they really did me proud in a way, although I can't take the credit for it. So I think we just can't judge these books by their cover.
AKS, I wanted to say something about this on this topic or something related.
The weaklings needing help.
Say that again, Vidya.
No,
So,
would
the
you like to
question
add
is,
something?
yeah, the question that we are discussing is that, there are some students who are not up to the mark. Do you give any special consideration, or you focus a little more on them to bring them on par?
That's your duty as a teacher, is it not? After all, everybody has to be given a chance to show motivation and improvement. And if they have initial hiccups, you have to devote a little more time to them.
And my last question, Vidya, is, there was a time everybody is crazy about surgery. Surgeons are gods, demigods. Now we have come to a situation where surgery is one of the least asked for subjects, because, a recent statistics have shown that out of first 100, only one or two took up surgery. What has happened to surgery, and do the teachers have any role to play in this sort of a degeneration?
No, I don't think it's the teachers. It is simply that many things that were surgical have now gone into radiology, into gastroenterology, into endoscopy. So they've all left the field of the surgeon. So people who are now coming, they see that the number of cases that you would get to do will be much less, because these patients will be stented, they will have a poem for achalasia, they will have a polypectomy done by the colonoscope or by the upper GI scope. So I think the field of surgery, for example, one of the worst affected is cardiothoracic surgery. Cardiothoracic surgery was, the number one in the 80s in earnings in United States. In 2025, they are down somewhere in 35th or 36th place, well beyond everybody else. Because, the cardiologists have taken over half their practice. The medical people have come up with so many drugs that no longer require surgery. So I think that is one of the main reasons why the popularity of surgery is down, because you can become other things and do almost equal to surgery, and with much less stress. Somehow, when you have a complication in endoscopy, it doesn't seem to be as bad as you have a complication during surgery, from the point of view of the administration or from the point of view of the patient. These people are hardly sued, whereas the surgeons are the ones, gynecologists, surgeons, these are the people who are sued most.
I think there are other reasons also, Patta. One of them is, of course, the surgery is no longer, MS is no longer an end specialty. It's only one degree before you stand in the queue for a super specialty or a fellowship, because it doesn't leave them at the end with sufficient confidence to be independent because of the weird nature of circumstances and large volumes. Therefore, and secondly, surgery requires a lot of investment to settle down after you complete. which is not so in dermatology or ophthalmology or some of the other specialties. Employability, immediate employability is much better in those. So there are a lot of market forces which decide these things, not only whether it is surgery or it is popular or not. I have done this study and asked a lot of people. The reasons why they don't take are nothing to do with the specialty as such, but the possibilities after they finish the theory.
Dr. AK, I also want to bring that the most popular in the first 100 rank seems to be radiology these days.
Yeah, radiology and dermatology.
But it is so difficult to get a radiologist who will come and do interventional radiology. They all want to do CT scan, MRI scan, they don't, and they want to do ultrasound scan. Ask them to do interventional radiology, 95% refuse. And we want them, we want an interventional radiologist, we are not able to get one.
I think
Interventional
lifestyle management
radiology
is also
requires hard work and requires you to take responsibility, whereas reporting from your house does not require that. It has become a specialty where images are reported from the house and the radiologist works in multiple hospitals at the same time and gets a lot of money. But you are right, it's very sought after because the fees in private institutions are 1.5 to 2 crores for dermatology and radiology as opposed to 40 or 50 lakhs for medicine, surgery and all.
also feel that people are making lifestyle choices.
Absolutely.
Amount of time which you need to do or invest when you're doing a surgical residency and on is
Work-life
tremendous.
balance.
Sorry?
Work-life balance.
Yeah,
Very difficult.
work-life balance. And so I think that is also an important component of the choices which people make these days. And you know, you don't have the stress of operating complications, and managing patients and relatives. So you realize that on one, a lot of time is invested, long hours, lot of stress, and then on the other hand, you have other options which don't necessarily have all these problems.
Far less stress.
Thank you, sir. Back to you, Vidya.
Yeah, so I think I attended a conference recently where this topic came up, and so somebody had a very interesting way of putting it. They said that most of the problems in medicine are errors of omission, but in surgery it's error of commission, errors of commission. So somehow the public and everyone, even the surgeons themselves, everyone feels much worse, or the consequences of errors of commission are more than those of errors of omission, though outcome may have been as bad for either. So we've been here for almost beyond 2 hours. So thank you, everyone. I know Dr. H.Ramesh wanted to leave, but we didn't let him go. Thank you, Professor Anandakrishnan, also for staying for so long. Thank you, Dr. Sadiq, for really putting this together. I know you spent a lot of thought on it as to what questions to, put forth to get the answers that everyone was waiting to hear. And thank you, audience, for being here. We have 46 people still logged in, even though it's been 2 hours and there were more than 80 people at one given time. Thank you, Dr. Ramesh Ardhanari, for interrupting your vacation to spend time with us. And thank you, everyone else who logged in. And of course, it was Radhakrishna's idea. This topic was chosen by Radhakrishna, and he helped me put the team together. We'll meet again next week with another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.